Welcome to the deep dive. If you're tuning in, maybe you or someone you care about has been dealing with abdominal pain that's just hard to explain.
Yeah, it can be a really frustrating journey.
Today, we're looking closely at something called Median Arcuate Ligament Syndrome, AL for short.
We're basically aiming to give you a solid understanding based on the medical literature, specifically a chapter from Rutherford's vascular surgery text.
Okay, so let's get right to it. The core idea, ALLS, it involves something pressing on the celiac artery, right?
Exactly. That's the main blood vessel feeding your upper abdominal organs, stomach, liver, spleen.
And the thing doing the pressing.
It's a band of tissue called the median arcuate ligament, part of your diaphragm, actually.
Okay, and this isn't exactly brand new thinking, is it?
No, not at all. The anatomy was described way back in 1917. Surgeons started figuring out how to surgically fix this in the 60s.
1963 for the first release I saw.
That's right, and a bigger group of successful cases reported a few years later in 67 really paved the way.
But here's the really puzzling part, and maybe why it's so tough to diagnose. This compression. You can actually see it on scans in a lot of people.
A surprising number, yeah. Maybe up to 24%, 1 in 4 people, could have this anatomical setup.
Well, almost none of them feel anything.
That's the crux of it. Less than 1% of those people are actually symptomatic. So just finding that compression on a scan doesn't mean it's the cause of the pain.
It's like finding a dent in a pipe that's working fine for most houses on the street.
Exactly. Which makes diagnosis really tricky. And our understanding of what's really happening in MELS has, well, it's evolved.
How so?
Initially, it was thought of purely as a vascular thing. Squeezed artery, less blood flow, pain, simple enough.
But it's more complicated.
It seems so. Increasingly, the focus is shifting towards a potential neurogenic issue, problems with the nerves, specifically the celiac plexus and ganglion, this complex network of nerves right around that artery.
Like the control center for the gut.
Kind of, yeah.
Yeah.
So maybe the nerve irritation is just as important, or even more important than the blood flow issue itself.
Okay, so not just a kinked hose. Today, we'll dig into the anatomy, these different ideas about how it causes symptoms, the pathophysiology.
Right, then how doctors try to diagnose it, and finally the current ways it's managed, all based on this literature.
Let's start with the anatomy then. You said the ligament is part of the diaphragm.
That's right. The median arcuate ligament, or ML, it actually forms pretty early on when we're developing.
Oh yeah? How early?
Between weeks 9 and 12 of gestation, the diaphragm starts up near the neck area and then moves down. The ML forms as part of that process.
Fascinating. And the diaphragm itself, it attaches to the spine.
Yep, through these structures called crura, usually originating from the lumbar vertebrae like L1 to L4, and they project upwards.
And the ML connects these cruras.
Exactly. It's the fibrous upper edge of the crura, forming a sort of arch or bridge right over the aorta.
The body's main artery.
Precisely where the celiac artery branches off.
So you got this fibrous archway, and the aorta and celiac artery are running right underneath it.
Correct. And for most people, there's plenty of space. No compression.
But in that 10-24% group.
In that group, the ligament sits a bit lower, or the artery comes off a bit higher, and you get some degree of compression. But again, usually no symptoms.
Just anatomical variation.
Pretty much. So seeing it is one thing, proving it's causing the problem is another entirely.
And you mentioned the nerves nearby, the celiac plexus.
Right. That's a really dense network of nerves located roughly around the T11 to L1 spinal level, and it spreads right across the aorta, very close to the celiac artery origin.
A busy neighborhood.
Very busy. And that proximity is really central to these newer theories about MELS potentially being a nerve problem.
Okay, so we have the ligament, the artery, the nerves, all close together. How does this setup actually lead to the pain and other symptoms people experience? Let's get into the pathophysiology.
Right. And it's key to remember, we still don't have the definitive answer. There are several theories floating around.
What was the first main idea? The vascular one.
Yeah, the initial thought was fairly straightforward. The artery gets squeezed, especially when the gut needs more blood, like after eating or during exercise.
Supply can't meet demand.
Exactly. Leading to ischemia, lack of oxygen, and the organs supplied by the celiac artery, stomach, liver, spleen, and that ischemia causes pain.
Seems logical. But you mentioned counterpoints.
Absolutely. The body is pretty good at developing detours, what we call collateral circulation. Other arteries can often pick up the slack.
So blood finds another way.
Often, yes, especially between the celiac artery territory and the area supplied by the next major gut artery, the superior mesenteric artery. Plus, studies trying to directly measure oxygen levels in the stomach.
Like gastric tonometry.
That's one method, yes.
Hmm.
They haven't consistently shown a direct link between the compression seen on scans and actual low oxygen levels or ischemia in the stomach lining, even during exercise when you'd expect it.
And doctors looking inside the stomach with endoscopy, they don't see damage from lack of blood flow.
Generally, no. You don't typically see the kind of ischemic changes or tissue necrosis you might expect if it were purely a severe blood flow problem.
Okay, so the simple vascular theory has some holes. What else?
There was the vascular steal syndrome idea. The theory was that blood might get diverted away from the superior mesenteric artery territory to try and compensate for the poor flow through the celiac.
So robbing Peter to pay Paul, potentially causing pain in the small intestine area.
That was the thinking. But it's proven really difficult to actually document that this steal phenomenon is happening consistently in MELS patients.
So that leads us to the nerve theories.
Right, the neurogenic theories. One angle is that the compression, or maybe just the turbulent blood flow around the compression, irritates the celiac plexus nerves.
Irritates the nerves themselves.
Yes, and this overstimulation could trigger reflexes that cause the blood vessels within the gut to constrict splanchnic vasoconstriction, leading to reduced blood flow and pain that way.
So the nerves are causing the blood flow issue indirectly.
That's one possibility. Another related neurogenic idea focuses more on direct mechanical compression or entrapment of the celiac ganglion itself by the ligament.
The nerve bundle gets squeezed.
Exactly. And remember, those nerves include pain fibers and fibers that control gut motility, how the stomach churns and empties.
Ah, so squeezing them could directly cause pain and mess up digestion, leading to nausea, bloating.
Precisely. It could alter the stomach's normal electrical activity and movement, and histological studies looking at the actual nerve tissue removed during surgery.
What do they show?
They show evidence of chronic irritation, inflammation, and those specific types of nerve fibers, pain and motor control fibers. It lends weight to this neurogenic component.
It really sounds like the nerve aspect is becoming more central to understanding bowels.
It certainly seems that way, but I have to stress the exact mechanism, the why, is still not fully pinned down, which, again, contributes to the diagnostic challenge.
Okay, a complex picture emerging. Let's shift to diagnosis then.
All right.
How do doctors actually try to figure out if MELS is the culprit, given all this uncertainty?
Well, it really starts with listening to the patient. A detailed history and a physical exam are the first steps. The goal is to see if the story fits and identify who might benefit from surgery.
But you said earlier the history and physical alone aren't usually definitive.
That's right. They can be non-specific or, frankly, pretty normal. But certain clues might emerge, like sometimes patients have had prior abdominal surgeries, maybe a gallbladder removal. That didn't solve the problem.
Interesting pattern. What's the most classic symptom they listen for?
Overwhelmingly, it's postprandial abdominal pain. Pain that reliably starts after eating, usually within the first hour or so.
Okay. Makes sense if digestion is triggering the issue. What else?
Weight loss is common, often because people are afraid to eat due to the pain. Bloating, nausea, sometimes vomiting. And pain that gets worse with physical exertion is another red flag for some.
And you mentioned a link to autonomic issues, like POTS.
Yes, there is a growing recognition of an association between MALS and autonomic dysfunction, including POTS, postural orthostatic tachycardia syndrome. That connection is still being explored, but it's definitely noted.
Fascinating. What about the physical exam? What might a doctor find?
Often, not much. Patients might be thin, their abdomen flat, and typically it's not tender to the touch. You might expect to hear a whoosh sound over the artery.
A brute.
Yeah, an abdominal brute. But actually, it's usually absent in MALS patients.
Any particular group more affected?
There's definitely a female predominance, maybe 2 or 3 women for every man diagnosed. Classically, diagnosis happens in the 30s and 40s, but some newer reports suggest it might be recognized earlier now, perhaps in the 20s.
And it often takes a long time to get diagnosed.
Unfortunately, yes. Many patients have symptoms for years, see multiple doctors, undergo countless tests before MALS is even considered. It's a long and often frustrating road.
That must be incredibly difficult for people.
Absolutely. And because initial workups are often negative, sometimes, sadly, patients might get dismissed. Their symptoms attributed to stress or psychological issues. You sometimes see notes in charts mentioning things like fibromyalgia or autonomic dysfunction, almost as associated conditions.
So they've likely been through the ringer with tests already.
Almost certainly.
Yeah.
Ultrasounds, maybe an ERCP, upper endoscopy, colonoscopy, motility studies, standard CTs, MRIs. Often everything comes back normal or nonspecific. And as I mentioned, a fair number have had previous abdominal surgeries.
Okay, so after the history and physical, assuming Mel's is suspected, what's next? Imaging.
Exactly. Imaging is key to visualizing the anatomy. Historically, back in the 60s and 70s, the gold standard was something called lateral aortography.
That sounds invasive.
It was, injecting dye directly into the aorta and taking x-rays from the side, often while the patient breathed in and out to see the change in compression.
What's used mostly now?
Nowadays, CT angiography CTA and magnetic resonance arteriography MRA are the go-to studies.
What do they show?
They give really detailed pictures of the celiac artery, the MAL, the aorta, other branches, and all the surrounding organs. Crucially, they can show that characteristic hooked or narrowed appearance of the celiac artery right where the ligament crosses it.
And they can see if it changes with breathing.
CTA is fast enough now that they can often capture images during both inspiration and expiration breath holds, which can demonstrate that dynamic compression. MRA can also be adapted for this. They also help rule out other problems.
What about ultrasound? You mentioned that earlier.
Right, transabdominal duplex ultrasound. It's becoming increasingly important, especially as an initial non-invasive test. Its strength is showing the dynamics of blood flow.
How the flow changes.
Exactly. As you breathe, the diaphragm moves, the aorta shifts slightly, and the relationship between the malleol and the celiac artery changes. Ultrasound can measure the speed of blood flow through the artery during inspiration and expiration.
So breathing in versus breathing out affects the compression.
Usually, yes. Breathing out tends to bring the ligament down, potentially increasing compression and blood flow speed. Breathing in often relieves it, and the speed decreases.
And there are specific speed numbers they look for.
Yes, they measure the peak systolic velocity, or PSV. Normally, it changes a bit with breathing. In mouths, you often see a dramatically high PSV during expiration, say over 200 centimeters per second, sometimes much higher, even over 500.
Wow.
And then that speed drops significantly, maybe even normalizes when the patient breathes in deeply or stands up. That dynamic change is a key indicator.
So it's not just high speed, but high speed that changes with breathing.
Precisely. Though it's crucial to note, ultrasound is very operator dependent. You need a skilled technologist who knows what to look for.
Are there other ultrasound signs?
Yes, things like turbulence in the flow, seeing the artery widen just past the narrowing poststenotic dilation, sometimes even reverse flow in the hepatic artery. Different researchers have proposed specific criteria based on combinations of these velocity changes and angles.
Okay. What about the CTA or MRA again? What specific things confirm MELS there?
You're looking for that characteristic focal narrowing of the proximal celiac artery, often with that poststenotic dilation. Seeing it worsen on expiration images and improve on inspiration is very suggestive. Also, seeing lots of extra collateral vessels can hint that the main celiac artery stenosis is significant enough to force blood through detours.
And that gastric exercise tonometry test, where does that fit?
It's less commonly used now, I think, but it aimed to show actual functional consequence, whether the stomach was experiencing ischemia during stress, like exercise, by measuring CO2 levels. A positive test could add weight to the diagnosis.
So pulling it all together.
Usually, the combination of a suggestive clinical story plus characteristic findings on duplex ultrasound and confirmed with CTA or MRA is enough to make the diagnosis.
Right. Okay, so once MEL is diagnosed, what are the options? How is it managed?
The management really boils down to surgical versus non-surgical, and for MELS itself, the non-surgical options are pretty limited in terms of long-term success.
What about things like nerve blocks? Injecting medication around that celiac plexus?
Percutaneous celiac ganglion blocks. They're used for pain relief in other conditions like pancreatitis or cancer pain. For male diagnosis or treatment, the data is pretty scarce.
So not really a go-to.
Not generally. Some small reports suggested patients who got temporary relief from a block did well after surgery, so maybe it has a very limited role, but it's not standard therapy for males itself.
Okay. What about trying to fix the artery from the inside? like angioplasty or putting in a stent?
That's generally not recommended as the primary treatment for mals caused by the ligament.
Why not?
Because the problem is extrinsic compression. The ligament is pushing from the outside. If you just inflate a balloon or put a stent inside the artery, that outside force is still there.
So the artery just gets squeezed again, or the stent might break.
Exactly. High rates of failure, rest stenosis, stent fracture, or migration, it just doesn't address the root cause. So endovascular treatment alone is usually contraindicated for mal compression.
Makes sense. You have to remove the outside pressure first.
Precisely. Though there's some thought now that maybe after surgical release, if symptoms persist and there's still some residual narrowing, angioplasty might be considered as an adjunct, but not as the first step.
Okay, so that really points towards surgery as the main treatment then. What does the surgery actually involve?
The cornerstone of surgical treatment is dividing or cutting that median arcuate ligament to relieve the compression on the celiac artery. And importantly, most surgeons now also focus on dividing the associated celiac ganglion nerve tissue that's often caught up in there too.
Ah, so releasing the nerves is considered just as important.
Yes, increasingly so. Given the neurogenic theories, the idea is that decompressing these neural fibers is critical to reducing pain and potentially improving some of the digestive symptoms like poor gastric motility.
How is the surgery usually done? Open or minimally invasive?
The trend is definitely towards minimally invasive approaches, primarily laparoscopic surgery.
Using cameras and small incisions.
Exactly. Typically using several small ports. The surgeon uses specialized instruments, often an ultrasonic scalpel or hook cautery, to carefully dissect around the aorta and celiac artery, identify the mal fibers crossing over, and divide them completely.
Sounds delicate.
It is. It requires careful dissection to expose the vessels and ensure all the constricting ligament fibers, and often a good portion of the surrounding nerve plexus tissue are released, usually extending the dissection a bit above the celiac origin on the aorta.
What about the older open surgery approach?
That involved a larger midline incision. It was effective for some, but generally associated with more postoperative pain, longer recovery, and higher complication rates compared to laparoscopy.
So laparoscopic is generally preferred now. What are the results like?
Generally quite good in appropriately selected patients. Studies show shorter hospital stays, quicker return to eating, and high rates, often 80% or more, of immediate or early improvement in abdominal pain and other symptoms.
But not always permanent.
There can be some late recurrence of symptoms in a portion of patients. Optimizing patient selection is still key to long-term success.
Is robotic surgery used for this too?
Yes, robotic-assisted ML release is also performed. So far, though, studies haven't consistently shown a clear advantage over standard laparoscopy in terms of outcomes. Sometimes operating times might even be a bit longer.
Interesting. And I think I saw a mention of a retroperitoneal approach.
Yeah, that's less common. Going in from behind the main abdominal cavity. Some reports suggest good results, comparable to open surgery, which again kind of supports the idea that releasing the nerves is key, as that approach focuses heavily on the plexus.
With all these options, is there a kind of standard pathway doctors follow?
One proposed algorithm by Kim and colleagues suggests starting with ruling out common things. If those are negative, move to duplex ultrasound. If that's suggestive or unclear, confirm with CTA or MRA, maybe angiography with pressure measurements.
And if Nellis is confirmed?
Then laparoscopic or robotic malrelease with ganglionectomy is usually the next step. Post-op, they follow up with ultrasound and symptom checks.
What if symptoms persist after surgery?
Then further investigation, like angiography again, to check for any remaining stenosis. If significant stenosis is still there despite the release, then maybe angioplasty or stenting could be considered. Or in rare cases, vascular reconstruction if true ischemia is suspected.
That algorithm helps put it all together. The chapter also had some case studies that really highlighted the complexities, didn't it?
Yes, they were very illustrative. Really drove home the point that imaging alone isn't enough.
What was the first case?
It was a patient where imaging suggested MELS, but clinically the picture didn't quite fit. Other health issues, maybe poor compliance and a different type of CT, didn't really confirm MELS findings, so not a surgical candidate. It shows you need that clinical correlation.
Right. And the next one, surgery helped but didn't fix everything.
Exactly. A patient with clear MELS on imaging and typical symptoms. Had the MEL release, the compression resolved, some symptoms improved, but persistent chest pain remained. Shows MELS release might not be a cure-all if other issues are present.
And case 3 was similar. Initial success, but then different symptoms reappeared.
Yeah, classic mouse picture. Great initial improvement after laparoscopic release, but then recurrence of chest pain, not abdominal pain, specifically with exercise. Follow-up scans showed the artery was still open, so maybe symptom overlap or other contributing factors.
And the last case sounded like a cautionary tale about operating without classic symptoms.
Definitely. Celiac compression seen on imaging, but the patient denied the typical post-meal pain. Had the surgery, some mild epigastric pain resolved, but bloating and nausea persisted, and he actually had significant post-operative complications.
So operating when the symptoms aren't quite right can be risky.
It really underscores the importance of patient selection. Just seeing compression isn't an automatic ticket to surgery.
What were the big lessons from these cases then?
I think the main ones are clinical symptoms are paramount, not just imaging findings. Lack of classic symptoms like post-exercise pain or having significant other health problems might predict a poorer surgical outcome. How bad the stenosis looks on the scan doesn't necessarily correlate with who gets better. And it reinforces the idea that maybe vascular compromise isn't the primary driver of pain for many MALS patients.
Really brings home the nuances. Okay, as we wrap up this deep dive, what are the main takeaways from the literature on MALS?
Well, it's clear that diagnosing MALS can still be challenging, but surgical treatment is definitely more established now. A key point, though, is realizing that the artery compression and the high velocities on ultrasound might just be markers for the real issue,
Which is,
which is likely the compression and irritation of that celiac ganglion neural network. The dysfunction seems to lie more with those nerves being squeezed or aggravated.
so fixing MALS isn't just about unkinking the artery, it's about freeing the nerves.
That's the current thinking, yes. Releasing the mal aims to decompress the celiac plexus, which hopefully alleviates not just pain, but also those other symptoms, nausea, vomiting, poor stomach emptying, and might even impact related conditions like POTS by calming down that nerve irritation.
But we're still learning.
Absolutely. Our understanding of who benefits most and the best long-term strategies is still evolving. We need more long-term data, larger studies. It's complex, requiring careful consideration of both the subjective symptoms and the objective test results.
So the bottom line for you, the listener, seems to be that MALS is complicated, that compression of the artery is often a sign pointing towards a deeper issue with the surrounding nerves.
Exactly. And accurately diagnosing it and deciding on treatment really hinges on carefully matching up your specific symptoms with those imaging findings.
And this leaves us with a provocative thought, perhaps. If MALS is increasingly viewed as having this major neurogenic component,
Why? What other conditions that look like vascular compression syndromes on the surface might also have a significant nerve involvement that we're currently underappreciating? Something definitely worth thinking about.